morning. How are we today? I would like first to congratulate everybody here who made it this early. I'm sure that, the alumni homecoming we had last night. It's going to be it's expected to have a harder time waking up and making up for a conference at this time. By the way, I'm Dr. Erdie Fadreguilan. I'm presently the chair of the Council of Electrophysiology. And this is going to be my last term. So when I was thinking about this symposium a year ago, after the 2016 PHA Annual Convention, I thought of bringing in experts from the region. Maybe at this point I would like to thank two companies who helped me in this one. Abbott Philippines, which formerly St. Jude Medical, and that of Medtronic Philippines for giving us this CME grant unrestricted to bring in two experts from the region, because I would want to focus for this year on a very common arrhythmia, as we know, as atrial fibrillation. And despite of that being common in our clinical practice, over the past 10, 15 years, we have seen a lot of information coming in, not only regarding its mechanism, but as well into the diagnosis and its management. In fact, radiofrequency ablation, formerly just initially being experimental, now becomes a routine part of therapy and in the available armamentarium when it comes to intervention of atrial fibrillation. So it's really an honor for me to bring the roster of speakers that I will be introducing. So I will introduce them first, all of them now, and I will call them later to give the talk in the lecture. So our first speaker, if you have attended the ECG session yesterday, you have seen him already, is that of Dr. Zulkeflee Muhammad from Malaysia. He is a consultant cardiologist in the National Heart Institute of Malaysia, and a certified cardiac electrophysiology specialist, that by the CEPS and USA in the Heart Rhythm Society. He will give a talk on a very important topic which we should be detecting, because some patients with AF are asymptomatic, and sometimes the only symptoms or the only sign that they would present with is a stroke already, so we would want to catch them earlier. Our second speaker will give us a talk on more challenging cases of atrial fibrillation. I've met him in 2010 in another PHA Council activity about heart failure. Dr. David Fu is Chee is head of the Department of Cardiology in Tan Tock Seng Hospital and head of Arrhythmia Pacing and Electrophysiology Service. He's an adjunct associate professor with the Yong Lulin School of Medicine in National University of Singapore. And our third speaker, of course, is a very dear friend, not only as a very good mentor before, and she serves continuously as, I'm sure, not only as an inspiration to me in my practice, but to a lot of us as well. So, Dr. Giselle Gervacio, and I really, had her in mind in presenting our local experience when it comes to complex ablation, especially of atrial fibrillation. She presently is a training officer of the PGH Cardiovascular Section. He's the incoming president of the Philippine Heart Rhythm Society, and she is our country representative to the Asia Pacific Heart Rhythm Society. She's really, in fact, moving or trying to make the PHRS prominent in the region, and we are trying to lobby, in fact, to hold the board meeting here in a year or two, which is going to be a very big achievement for the local Heart Rhythm Society. She is a clinical associate professor of the University of the Philippines College of Medicine and the head of electrophysiology section at the St. Luke's Medical Center in Global City. So to talk about silent subclinical atrial fibrillation, may I call on Dr. Zul?
A very good morning to all the ladies and gentlemen. Thank you for the kind introduction by Dr. Erdie. It is indeed an honor for me to come to Philippines on my first trip here. and represent Malaysia in general. So this morning we're just going to try and spend some time talking about the subclinical atrial fibrillations in terms of detections and management. I have nothing to declare. So briefly, the talk, we're just going to discuss about the epidemiology of atrial fibrillation and the stroke per se, and then diagnosis of silent subclinical atrial fibrillations and stroke risk based on the silent subclinical atrial fibrillations, and how do we actually manage that. We're all familiar with these slides, I guess, based from the Atrial registry done in the United States. Unfortunately, a lot of missing data in our region in terms of epidemiology of atrial fibrillation per se. Even in Malaysia, we do not have kind of overall perspective data on our own populations. It has been lacking, and there's one thing that we actually probably have to work more on that and to get more data in terms of Asia Pacific region. It is a scary thought to know that the predictions of atrial fibrillations over the next 20 to 30 years will probably be up to 16 million per year. This is based on the US. If you look at the global populations, the predictions of that could probably reach up to 20 to 30 million throughout the whole world. And what is striking is that up to 1/3 of these populations will not have any symptoms of atrial fibrillations. And that's hence the significance of discussing about this further on. We know that patient with atrial fibrillations has 5-fold increased risk of developing stroke as compared to patient without atrial fibrillations. What is also striking about patient with atrial fibrillation is that the stroke that they have is actually far more devastating than stroke the patient has without the presence of atrial fibrillations. And we know that about 90% of the stroke caused by atrial fibrillations are thromboembolic, and 90% of that are thought to come from your left atrial appendage, and hence all of this hype about the EP world doing atrial appendage occlusions and all of that. Clinical presentation of atrial fibrillations, as I mentioned before, 1/3 of the patients will not have any symptoms at all. And in fact, more than half of them as they presented with a stroke as their first presentation. And we know already that stroke with atrial fibrillations carries significant morbidity and mortality. So we know that from the earlier studies, trying to relate symptoms of atrial fibrillations with the presentation of atrial fibrillation itself is not reliable. Not to say not reliable, but most patients, 95% of the patients with clinical atrial fibrillations do not have any symptoms. And more often, the presentation of atrial fibrillations are related to hemodynamic compromise, which is here, dizziness, heart failure, or the feelings of atrial tachycardia itself. So for those patients who had symptoms, it's probably easier for us to see them in the clinics and detect them because they actually seek medical advice. But for the patient without symptoms, their risk of morbidity and mortality are more or less the same as patients with the symptomatic atrial fibrillations. But the problem is that we tend to pick them up from the secondary complications of atrial fibrillation itself, i.e. from the heart failure, sudden death, or even ischemic stroke itself. That will make subclinical atrial fibrillations is one of the important things that we have to think about, especially when patient presented with stroke of unknown origins. Just briefly, the definitions about subclinical atrial fibrillations, as the term itself state that, the occurrence of atrial fibrillation without the clinical symptoms, it has to be associated with AF burden, and in the EP world we tend to call it atrial high rate, based on the devices that we use to detect these subclinical atrial fibrillations. Unfortunately, a lot of the discussions about how much of atrial fibrillations needs to be detected before you could actually clinically diagnose as silent atrial fibrillation is still a matter of investigations and debate amongst the leaders of atrial fibrillations experts. The reason why we need to detect these silent or clinical atrial fibrillations is more to do with the earlier interventions in terms of particularly stroke preventions, and that would also help us to assist in terms of decisions whether we need to initiate therapy or not for patients, especially with cryptogenic stroke, which will be discussed a bit more. This is one of the typical examples that we see in the EP clinic, especially for patients with atrial sensing or dual chamber pacemaker. These signals that was detected by the atrial leads will just tell you the rate of the atrial activity at any given time. It does not tell us the morphology of the P wave, nor does it tell us the morphology of the QRS. So based on this high atrial rate, you can actually make the diagnosis of atrial fibrillations, being asymptomatic as the patient presented to you, hence fulfill the criteria of subclinical atrial fibrillations. As physicians, you have to look at this change or the pattern of the high atrial rate specifically, because some of them may just actually be atrial tachycardia rather than atrial fibrillations. And hence, the definitions of AHRE to make us diagnose atrial fibrillations has been arbitrary. A lot of people start to use the rate, and there has been a range between 190 beats per minute up to 220 beats per minute, depending on the studies that you looked at. We discussed about the associations of atrial fibrillations and a stroke. And this is the kind of the initial threshold which would start people to look more and more into the subclinical atrial fibrillations. The presence of or the incidence of cryptogenic stroke. By definition, the stroke which does not have any clinical cause or etiology. And 30% of all stroke are cryptogenic, and based from the trials, we know that up to third of these patients will actually have subclinical atrial fibrillations if you were to follow them up and monitor them. Now, really, we are talking about the tip of the iceberg in terms of diagnosis atrial fibrillations subclinically, because a lot of patients, the one that we actually diagnose are those who actually had the devices. So patients without the devices or any form of monitoring will not have a chance to be detected from the presence of subclinical atrial fibrillations. Now that brings on to the studies of crystal atrial fibrillations, in which people look at the evidence of randomized patient to device, implantable device monitoring versus a standard mode of monitoring for the detections of atrial fibrillations in patients with a stroke or cryptogenic stroke. And the primary endpoint was just to look at the detections of atrial fibrillations at 6 months, 12 months, 1 year, and 36 months. The main conclusion from the studies is just that the implantable cardiac monitoring are far superior than the standard monitoring of 12-lead ECG, even 24-hour monitoring in terms of detecting atrial fibrillations at those given intervals. And it can be up to 30% at 36 months. Now, the importance of that is that the detections of atrial fibrillations, as we know, change the management of anticoagulations for the patient with a stroke. We know that previously, even if you to talk to the neurologists, they are not there to start patients on oral anticoagulations without knowing whether the patient had atrial fibrillation or not. And of course, this plays a significant role in terms of managing this patient with a stroke, because we know that if the patient were to have atrial fibrillations, treating them with oral anticoagulations actually reduce further stroke by up to 60%. This is just a summary following the same studies, and people start to look at this cryptogenic stroke from 2013 onwards, and a follow-on from the Crystal-AF studies. People also do the Embrace clinical trials, which look at about 570 patients of cryptogenic stroke. The points that I wanted to show with this slide is that all of these clinical trials actually showed that the longer you monitor these subclinical patients with a cryptogenic stroke, the higher the chance of you detecting the presence of atrial fibrillations. And hence the European guidelines, although being a bit more defensive in the sense that I think partly because they are considering the cost of putting everybody with a cryptogenic stroke with invasive monitoring. Their first, it doesn't project it well there, that the first, as a class 1B indication for monitoring this patient are still based on the clinical findings, i.e. they would advise the patient to check, or the physicians to check the patient pulse and to assess that with the clinical symptoms. And they put the implantable loop recorders as a class 2A indications for patients with cryptogenic stroke. And this is the landscape of the devices that has been developed over the years in terms of the cardiac monitoring. I'm sure we're all familiar with the 24-hour Holter. The difference between this is that for the event recorder, you can actually put patients longer than 24 hours. And this is the series of the implantable loop recorders. As you can see, previously we have to do active implantations. Now with the link devices, it is actually just injectable, which you can do it in the outpatient clinic setting. And the size itself is quite small. I'm not sure, I've never seen it before, but when I speak to my patients, this is actually just about as big as the contraceptive devices, which is the Implanon. So I'm not sure whether any of you familiar with that injectable device. But it just goes to show that with the advance of the technology, the tools that we use to detect subclinical atrial fibrillations become more and more smaller and easier to implement. And then we have this wearable patch that you can use it for up to 14 days. And there is no kind of wearable wires. And then this is one of the latest devices that you can actually use to detect your rhythm. I have seen one of these in the Heart Rhythm Society meeting, but unfortunately I'm not sure whether it's available in this region or not. Maybe in Singapore it probably has it. Part of the issue is that is to do with the licensing of this product. It's only compatible with the iPhone. They have these two electrode pad at the back of the phone, and you just put your two thumbs, which is more or less equivalent to your kind of lead 1 ECG, And the quality of the ECG are very, very good. You can actually see P and the QRS, and that will help to detect the presence of subclinical atrial fibrillations. And we all know that the longer or the harder you look for the atrial fibrillations, the better the yield of the detections. And of course, with the advancement of the technology, these detections could actually go up to about 90%. But unfortunately, all of these are not without the cost. So in terms of clinical practice, perhaps in the future, all of those detection devices would be cheaper and easier to be used, and with the hope that more and more atrial fibrillation will be able to be picked up from these devices. This is just a summary to show that the reliability of the newer devices in terms of detecting atrial fibrillations. A lot of these recent wearable or patch that we use nowadays has very high sensitivity and specificity in terms of detecting atrial fibrillations. Now, this is one of the few trials that, based on the cardiac implantable electrical devices, the incidence of atrial fibrillations, which was detected by the devices from the beginning of the MOSE trials to the recent pacemaker and ICD in 2016, if you look across the board, that this patient who had the devices implanted without the clinical atrial fibrillations at the beginning, if you were to monitor them, the incidence of detecting new onsets of atrial fibrillation is more or less the same, i.e. is about 30% in each of the study groups. It goes to show that the more, basically the reason why these implantable devices were able to pick up atrial fibrillations is because of the longer durations of monitoring of the patients. Now the question goes in terms of this subclinical atrial fibrillation, is that how much of atrial fibrillation, so what is the duration of the atrial fibrillation that needed for it to be significant in terms of the association with the stroke. If you look at the earlier trial, the MOSE trial, basically the trial was designed to look at the difference in terms of atrial-based pacing for patients with a sick sinus disease in terms of prevention of atrial fibrillations. What they also found, apart from the primary outcome of the studies, is that if you were to detect atrial fibrillations in this subgroup analysis, you would have an increased risk of thromboembolic events, particularly stroke, of up to 2.79 hazard ratio. And interesting to note that this MOSE trial used 5 minutes as their cutoff point for significance or the definitions of subclinical atrial fibrillations. 5 minutes means the patient has to have a subclinical or high atrial rate in 5 minutes per day for you to detect or differentiate whether the presence or the absence of subclinical atrial fibrillations. Following this, the Italian group looked at the same class of the patients, i.e. the pacemaker which was implanted for bradycardia patients in the 8500 studies. Again, they use the difference between this is that they use a cutoff point of 1 day as the significant incidence of subclinical atrial fibrillation in association with thromboembolic events. The relationship between atrial arrhythmia burden and the stroke risk studies, or the trend studies, which is a prospective observational study looking at the bigger numbers of patients with a CHEST score of 1, receiving again the devices for whatever indication, either pacemaker or ICD. For this group of investigators, they use 5.5 hours of AF burden as clinical markers for association with the stroke. And then the recently published ASSERT trial in 2012 used a cutoff point of 6 minutes of high atrial rate as a cutoff markers for the significance development of stroke or thromboembolic event in subclinical atrial fibrillations. But interestingly, when they look at it specifically or further sub-analysis which was done, as you can see here, the durations of atrial tachycardia or high atrial rate in corresponds to the ischemic stroke or embolisms. The higher the events of the high atrial rate, it gives you the higher relative risk of developing thromboembolic events. So in terms of cutoff point as to whether 6 minutes or 1 or 24 hours, it depends on the region which they looked at, because the most trials actually done in the United States, and most of the other trials were done in Europe. And as you can see here, all of these variations of cutoff point is still not kind of unifiedly defined by all of the experts. And hence, if the guidelines in the different regions follows according to what evidence they have per regions. Now, we know what the studies previously have shown is that there is an association between subclinical atrial fibrillations and the risk of stroke. But interestingly, when they look at the causative cause of, direct relationship between subclinical atrial fibrillations and the presence of stroke, they found that, when they look at the ASSERT trial itself, or the patient who had a stroke after the implantation of the devices, 65 of the patients developed subclinical atrial fibrillations after the development of the stroke. Meaning to say is that they cannot actually find a temporal relationship between the subclinical atrial fibrillation itself with the stroke. But they do know that there is an association between subclinical atrial fibrillations and a stroke. And a similar trend we'll seen on the TRANS trial, that the systemic embolisms occurs within 30 days of the detections of AT or AF episodes. What they were trying to do is that now these clinical findings of subclinical atrial fibrillation in terms of direct cause to the stroke was not, the initial analysis was not done based on the other risk factors for stroke. So the group from the AT500 trial, which is led by Boto et al., tried to quantify the subclinical atrial fibrillations with the CHEST score to see whether is there any association between combination of the two parameters in terms of developing or stroke risk. It's a bit more complicated analysis, which they divided the group into three, between no symptoms less than 5 minutes a day, 5 minutes to 24 hours, and more than 24 hours. And they divided into a group which is a low risk or moderate risk, i.e. CHEST score 2 or less, versus high risk CHEST score 2 or more. what they found was that if you were to compare these two groups versus these three sub-category, you do have a significant, with p-value of 0.03 hazard ratio or risk as compared to patient without or lower CHAT score. So what the expert panelist is trying to say is that the presence of subclinical atrial fibrillations per se has no direct relationship with the development of stroke, but the presence of atrial fibrillation, as we know from the 1855 Virchow's triad, the hypercoagulable state that caused by atrial fibrillations due to the stasis and the poor blood flows and a change in the constituencies of the bloods would predispose patients to develop stroke. But as I mentioned before, the presence of the silent atrial fibrillations is actually make the patient become more prothrombotic. But the process of developing stroke itself is a bit more complicated than just the mere presence of subclinical atrial fibrillations. Now, back to the questions about whether then do we need to treat these patients with the silent atrial fibrillations with oral anticoagulations. And we know that from the clinical atrial fibrillation with the CHAT-VAS score, or either use CHATS or CHAT-VAS score, the higher the score, the higher the incidence of thromboembolisms per year. If you were to have CHAT-VAS score of 6, your risk of developing stroke within a year is about 9.7%. And the same goes with your CHAT score, meaning to say that any patients in CHAT score of 2 or more, or CHAT-VAS score 2 or more, will have, which is what we call higher category risk of stroke. Now, the issues with the subclinical atrial fibrillations is that whether is that really a risk factor or just a mere risk marker for stroke. And the risk-benefit analysis for the use of oral anticoagulation in treatment of subclinical atrial fibrillation has not been looked at in the major clinical trials. And the only trials that we have so far is the IMPACT trial, in which they will look at the high atrial rate group device in the device patient as a guide to help the physician in terms of initiating the oral anticoagulation or not. Based on the CHAT score, i.e. the low risk, intermediate risk, and high risk, these patients were randomized into treatment group versus non-treatment group. Treatment group meaning if they were to have the presence of high atrial rate for the CHAT-VAS score of 1 or 2 for more than 48 hours, they will initiate the oral anticoagulations. What is interesting about this is that they follow this patient for 30 days, and if they were to find from the device that the patient is no longer having atrial fibrillations, they will stop oral anticoagulations. For patients with a moderate risk, they use a lower cutoff point of 24 hours to decide whether they need to start on oral anticoagulation or not. And they will follow this patient for 90 days. And for a patient with a high risk group, they do not consider any of these durations, but any evidence of high atrial rate, they would initiate oral anticoagulations and would continue throughout the study period. What they actually found is that after, I think the study was actually stopped after 12 months follow-up because the education committee found out that the risk of thromboembolisms are more or less similar in between the intervention versus non-intervention group. But there's a lot of issues about these studies. First and foremost, the choice of oral anticoagulation were actually at that time using warfarin. And if you look at the subgroup analysis of these patients who are on warfarin, there were about 43% patients who will actually drop out from the treatment. And hence, the conclusion from the studies are not, even though this is a randomized control trial, but this is not as strong as you would expect. Patient, I mean, one of the arguments was that the issues about the choice of oral anticoagulations, and one of the questions raised by the people who analyzed the study was that would the study outcome would be different if we were to use newer oral anticoagulations. And hence, further study was actually designed and currently still recruiting patients. This is the study of apixaban for the reduction of thromboembolism in patients with a device-detected subclinical atrial fibrillation or atresia. They actually tried to randomize 4,000 patients to look at the difference between patients with high atrial rate and randomized into receiving aspirin plus placebo apixaban or aspirin plus the active apixaban group. And the results of these studies are yet to be analyzed. So, as I mentioned before, in terms of what do you do when you see patient with high atrial rate in your clinic and in your clinical practice? Now, the European and the American has a different proposed algorithm for this. This is the ACC proposed algorithm, which was published in 2000, just at the beginning of the year. That if you were to detect high atrial rate, first you have to confirm whether it is actually atrial fibrillations. They use a cutoff point of 5 minutes, and then you use CHAP-VAS score as additional parameters for you to decide whether you need to start this patient on anticoagulation or not. Interestingly, if you look at the European guidelines, for the same device-detected atrial tachycardia or subclinical atrial fibrillations, which is this group here, they use a cutoff point of 24 hours with a combination of CHAP-VAS score, and then you decide whether you should start this patient on anticoagulation or not. So I think, ladies and gentlemen, as a conclusion from the talk, based from the trials and evidence that we have so far, we do see a lot of these patients with subclinical atrial fibrillations. The association between the direct relationship between subclinical and the risk of stroke is not yet established. But we have to guide the patients based on their other risk factor for stroke, i.e. the CHAP-VAS score, in terms of deciding whether you need to put this patient on oral anticoagulation or not. I think I will end this talk by that slide. Thank you very much.
Before we call our next speaker, we will be entertaining questions after our three speakers finish their lectures. Our next speaker is Dr. David Fu Chee from Singapore.
Good morning. It's a pleasure to be here this morning to share about at least one interesting and challenging case with regards to atrial fibrillation. These are my disclosures. So in a short 20 minutes or so, I'm going to talk about Mr. TTM, who is actually just recently admitted and is still actually admitted in our hospital. So he's a 70-year-old gentleman with a history of hypertension, but he's non-compliant to his medications. He was actually admitted for acute onset of giddiness and headache, and his symptoms were worse with head movements. On examination, he was actually unsteady on walking, and he had recurrent vomiting spells. His blood pressure was actually very high, with a systolic of 198 millimeters per mercury and a diastolic 100 millimeters per mercury. So in view of his symptoms, he was the emergency department actually sent him for an MRI of the brain. So this was the MRI. So as you can see on the MRI, perhaps it's not the lights are not projecting, or the lights are too bright, but essentially this is an MRI, and if you look, there is a left posterior cerebellar acute hemorrhagic infarct. So that caused his symptoms and unsteady gait. So he was actually admitted to the neurology department in the hospital. And so under the neurology, or in view of his posterior cerebellar hemorrhagic or infarct with hemorrhagic conversion, he was actually admitted under neurology in the high dependency unit for 1 to 2 days with the aim for meticulous blood pressure control. As you recall, his blood pressure was very high in the emergency department. So subsequently was moved out of the high dependency department into the general ward and started some rehabilitation exercises to try to improve his motor function. So however, or rather throughout his period in the normal ward, he was put on a telemetry and recurrent daily ECGs. As our previous speaker mentioned, this was in the aim of trying to catch or trying to detect any possibility of atrial fibrillation as a cause or one of the causes for his stroke. So on day 6 of his telemetry, he was still on day 6 of telemetry, it showed some abnormal readings on the telemetry, so on the rhythm strip. So a 12-lead ECG was then performed, which actually showed atrial fibrillation with a fairly rapid ventricular rate response. Ventricular response. So he was admitted under neurology, and because of the stroke with hemorrhagic conversion, he was not prescribed any anticoagulants because there weren't any documented AF before that, and he wasn't prescribed any antiplatelets. So the question now is, what will you do next? Unfortunately, it's not a audience response system, but perhaps we can have a show of hands if you are willing to. So the discussion was then, where are we at right now? Day 6 of stroke with hemorrhagic conversion, and there is atrial fibrillation which was caught on monitoring. So the options are, number 1, should we give him aspirin? Number 2, should we give him dual antiplatelet therapy, such as aspirin and clopidogrel? Number 3, should we give him warfarin? Number 4, should we start him on the non-vitamin K oral anticoagulants? In Singapore, we have 3, which are Dabigatran, rivaroxaban, and apixaban. Should we start on one of these 3? Or number 5, should we refer him for a left atrial appendage occlusion, which is not commonly done, and it's probably, as far as I recall, there's less than 5 cases done in Singapore. And lastly, should we refer him for AF ablation? But bear in mind, at least for 5 and 6, where you have a left atrial appendage occlusion or a AF ablation, patients would still be subjected to a short window of anticoagulation post-procedure. So perhaps in a short span of time, maybe I can take a vote. Who will start him on aspirin? Anybody? Who will start him on dual antiplatelets? No one. Who will start the patient on warfarin? Okay, I see one hand. Well, running out of options already. Okay, warfarin 1. Who will start this patient on the non-vitamin K oral anticoagulants or the NOACs? Okay, more. Okay, 4, 5. Okay, it's like, we are auctioning, putting up numbers. Okay, who will refer him for a left atrial appendage occlusion? Okay, 1. Okay, and anybody for AF ablation? No? Okay, maybe 1. Okay, all right, so the winner, okay, I don't have the number. So the winner looks like is non-vitamin K oral anticoagulants. Okay, so let's see. Now, this case is very, very interesting in the sense that, or rather challenging, because there are no definite guidelines to actually help us with this. If you dig into the ACC or ESC, you don't have actually the answer beautifully crafted out for you. So it's probably very difficult to see this because of the lighting, but essentially, in a patient with a TIA stroke, assuming that this patient falls under the hemorrhagic arm, right, and falls under no prior anticoagulation, then actually on the ESC guideline, they actually mentioned consider LA, left atrial appendage occlusion. But if you consider this as an ischemic stroke, purely a ischemic stroke, and ignore the hemorrhagic conversion, then in a certain sense, you will consider this as at least a moderate to severe stroke. And then you will consider anticoagulation at least after 6 or 12 days. So our answer, the guidelines don't really help us in a sense. So because this is neither really an intracranial hemorrhage, because it is an ischemic stroke with a hemorrhagic conversion, or it's neither a pure ischemic stroke. So it didn't really help us in that matter. But as I mentioned, the patient was admitted under neurology, so not under cardiology, of course. So our neurology colleagues, well, in their internal discussion, decided to start the patient on aspirin and clopidogrel. Okay, so like I said, there is no right or wrong answer, which is why it's even more challenging. So the patient was then started on dual antiplatelet, so the favorite at the time was aspirin and clopidogrel on day 6. So what happened next? On 3 days later, after starting dual antiplatelet therapy, the patient complained of worsening left-sided weakness, numbness, headaches, and he became cold and clammy. And because the neurologists have access to quick brain imaging, so urgent CT was done. I think most would probably guess what will come next. So on dual antiplatelet therapy, the hemorrhagic conversion became a real big hemorrhage, real bleed in the posterior cerebellar. Okay, so this was very alarming. So he was again whipped back to the, now from a high dependency unit, he's now upgraded to the intensive care unit. All right, so he was transferred down to intensive care unit, and urgent neurosurgical consult was made, and it was decided that he would quickly need a posterior fossa decompression surgery and a drain, okay, to relieve the increase in intracranial pressure. So 3 days after antiplatelet therapy, his hemorrhage in the posterior, in the cerebellum became worse, requiring surgery, which is quite traumatic. So all antiplatelets obviously were stopped at this point of time. When he went for surgery, he was given lots of platelet transfusion as well as any potential, any plasma transfusion as well, just to attempt to reverse whatever coagulation defects that the patient might have. So post-surgery, he was actually doing very well. Okay, so post-surgery, without any antiplatelets or anticoagulants, he's actually recovered very well, and he's actually stayed in the hospital to undergo rehabilitation again. So he's back in the normal ward. So he had a drain, and he's essentially later on converted into a ventricular peritoneal shunt. But he actually recovered very well, and he started to resume most of his motor functions. However, because of the cerebellar nature of his stroke, there is still some issues with coordination. But as he goes back to the usual ward and during rehab, it was discovered that his AF was actually paroxysmal, so it would actually come on and come off. So it is paroxysmal. Now, so the question is now 8 weeks since the stroke and maybe about 7 weeks after his surgery. What will you do next now? So you are faced with another question now, 8 weeks. So based on the ESC guidelines, if consider it as a severe stroke, we actually after 12 days we need to do something. But now it's already 8 weeks, and we're monitoring in this patient in the hospital religiously. And so we are back to the same question, what to do next? So it's the same 6 options now. Remember, he has not had anything because of the bleed. So number 1, aspirin. Number 2, dual antiplatelet. Number 3, warfarin. Number 4, the NOACs. Number 5, the left atrial appendage occlusion. And lastly, AF ablation. So maybe I have a quick show of hands. Who will give him aspirin? No? No? Okay, you are anti-aspirin people. Okay, any dual antiplatelets? Any aspirin clopidogrel? No? Okay. How about warfarin? Okay. After yesterday's talk, nobody likes warfarin now. Okay, so anybody for NOACs? Okay, more hands are up for non-vitamin K oral anticoagulants. How about LA or left atrial appendage occlusion? Oh, okay, got more now. 2, 3. Okay. All right, and AF ablation? 1, 2. Oh, okay. We're going to have increased AF ablation in this country soon, I think. That's very good. Okay, so again, just want to emphasize on a point that even if we go for LA appendage occlusion, there is still, as well as AF ablation, there will still need a window of anticoagulation post-procedure, especially in patients who have a higher CHA2DS2-VASc score. So remember, this patient is still not under the care of cardiologist. Okay, I don't know whether there are any neurologists here. I hope not. Okay, but anyway, so still under the care of neurologists. So absolutely right. We actually, or they actually considered the prospect of a left atrial appendage occlusion device, but they decided to start rivaroxaban, okay, which is actually, well, I would say the so-called the cheapest in our country out of the 3. And despite the fact that the patient has a normal eGFR, you recall that in the NOAC trials, at least for rivaroxaban, in the ROCKET AF trial, patients who have a normal renal function, they actually get the standard dose, which is then 20 milligrams a day. But because this patient has had the ischemic stroke with hemorrhagic conversion, the decision was to put this patient on a reduced dose of rivaroxaban instead of the standard dose. So he was put on rivaroxaban, and he was monitored for another 1 week or so, and he was discharged altogether about 9 to 10 weeks after he presented with a stroke. So in all things, everything seems to be very good. Okay, so he was taking rivaroxaban, now being compliant patient. He was non-compliant to his hypertensives, and now he comes into cardiology, and we finally got hold of this patient, fortunately or unfortunately. So it's 4 months after he has had a stroke, and now he's got gotten into cardiology when he presented with acute chest pain and palpitations while he was doing some rehabilitation exercises. His ECG showed that AF when he was admitted to us, and his cardiac enzyme shows that elevated troponin levels. So he was treated for a non-STEMI or non-ST elevation myocardial infarction, and with a view of an invasive strategy, which is an early angiogram with potential percutaneous coronary intervention, or PCI. So we actually stopped his rivaroxaban one day before, and we referred him to our interventional colleagues for angiogram through the radial approach, so that it will minimize the risk of bleeding as compared to a femoral approach for angiogram. So this case is not only an EP case, it now becomes an interventional case. Okay. So this is, all right, so this is the angiogram. Okay, so this is the diagnostic angiogram. So if, for the audience who are not very familiar with angiogram, this is from a right radial approach. So this is the left coronary anatomy. So if you see carefully, this is the left anterior descending artery. You can see a very tight stenosis at the proximal mid segment of the left anterior descending artery, or LAD for short. So, okay, so on the right side, on the right side, you can see that the same segment has been stented. The angioplasty was done, and stenting was performed. Trying to get this. Okay, and stenting was performed down here as well. So the interventionist decided to put what they call a biofreedom stent based on a study or two in the New England Journal, which I think was published quite recently. I think, if I'm not mistaken, it's called the Leaders Free Trial, which then suggested a short duration of DAPT with this type of stent for a month is quite okay or pretty safe. So now we are with a dilemma. So now he's got a stent, a drug-eluting stent, and he's got a history of a stroke with hemorrhagic conversion. So if you have attended talks talking about PCI and AF and how to treat, you realize that there's no real good evidence out there to actually point us one way to another, except maybe for one recent trial, which I will discuss. So at this point of time, what would your strategy be in terms of anti-thrombotic or anti-platelet strategy? So maybe I give a show of hands. Would how many will go for a DAPT, either aspirin or clopidogrel, or aspirin or ticagrelor? Anybody? No. Okay. Dual antiplatelet therapy, this audience. Okay. Warfarin and DAPT? No. Warfarin or single antiplatelet, be it warfarin aspirin or warfarin or clopidogrel. Anyone? Okay. There's no left atrial appendage occlusion if you think that there's going to be an option number 8 later on. Okay, so anybody for warfarin? One, okay. Anybody for a single non-vitamin K oral antagonist? No? Okay. How about non-vitamin K oral antagonist, oral anticoagulant, the new ones with one single antiplatelet? Okay, at least half the audience. How about the low dose? Okay, so number 6 was a standard dose. How about low dose vitamin K oral anticoagulant with DAPT? It's a mouthful. Okay, so it's a toss. Excellent. So it's a toss between 6 and 7. Okay, nobody chose 1 to 5. So what does any guidelines to help us to make that decision? Unfortunately, again, the guidelines are not very clear because, as I mentioned maybe yesterday, that AF is a very difficult and very individualized approach for every single patient, and not one patient may be the same as the other. So again, look at the ESC guidelines. They have actually divided into elective PCI and acute coronary syndrome. Now bear in mind, these guidelines are really consensus view. So it's not really based on huge randomized controlled trials. So based on the ESC guidelines, if the patient undergoes, in patients with AF, right, and you need to anticoagulate them for stroke prevention and needs PCI. In the top part, which shows elective PCI, then the recommendation is for triple therapy, a NOAC plus aspirin plus clopidogrel for 1 month or so, and then you convert it to a double therapy, which is either a NOAC plus aspirin or clopidogrel, and after 1 year, continue with NOAC as a monotherapy. Okay, on the other hand, in acute coronary syndrome, in patients with acute coronary syndrome, then the option is to prolong the triple therapy, which is NOAC plus DAPT, dual antiplatelet, for about 6 months or so, and then for the next 6 months, do a double therapy of NOAC plus an antiplatelet, and after 1 year, a NOAC monotherapy. So this is really just a guide. But again, remember, in our patient, doesn't really fit nicely into either of this, because remember, antithrombotic and antiplatelet therapies in combination will predispose a patient to a higher risk of bleeding, especially in this patient who has had a bleeding event intracranially. Okay, so what needs to be considered then for our patient? Essentially, he has got a recent stroke and hemorrhagic conversion, which require neurosurgical intervention. He has atrial fibrillation now, a chest VAS of 2, more than 2, at least for hypertension as well as stroke. He's got acute coronary syndrome. He presented with non-ST elevation MI, and he's got a drug-eluting stent. So all these 4 points make it hard, and there is actually no randomized control studies to actually have an inclusion criteria looking at all these 4, which is very difficult. So what is the best we have so far? So the best we have so far, which is a recent study about 6 months ago, published in the New England, which is called the Pioneer AF-PCI, looking at the prevention of bleeding in patients with AF undergoing PCI. Remember, these patients are AF and going PCI, and not like our patient who has had an event intracranially and AF going for PCI. So in this clinical trial, if without going too much in detail, in group 1, essentially they put as a rivaroxaban at a lower dose and a clopidogrel. Group 2 is a NOAC and DAPT, and group 3 is a traditional Warfarin, as well as the antiplatelet therapy. So what they find is that in group 1 and group 2, where the NOACs were involved, that the bleeding risk is actually much lower than patients who are Warfarin and dual antiplatelet therapy. However, though the bleeding risk is lower, the outcomes in terms of cardiovascular events with a follow-up of at least 1 year is actually quite similar in either arms. Okay, so for our patient, then now we brought in, because cardiologists, admitted under cardiologists, we brought in the patient and discussed the case with his neurologist and neurosurgeon, as well as the interventional cardiologist. And then, so we decided, based on his clinical profile, to kind of manage him as for a Pioneer AF-PCI patient. And we started him on rivaroxaban at the reduced dose, as well as clopidogrel 75 milligrams a day. So we actually were concerned about risk of recurrent intracranial bleeding, so we did a CT brain before discharge, and there wasn't any evolution, and so he was discharged with very close outpatient follow-up, and was just discharged yesterday, as far as I was told, and is doing well so far. So the take-home messages is there are actually many possible combinations in terms of oral anticoagulant and non-pharmacological approaches for stroke prophylaxis in patients with AF. And there are very few randomized controlled trials looking at a combination of AF and stroke prophylaxis in combination with PCI. So depends on your patient's presentation. And I mentioned time and again that most AF patients require individualized approach in the management of rhythm, rate, and anticoagulation therapies. So with that, I thank you for your kind attention.
Okay, our next speaker is Dr. Giselle Gervacio.
Good morning. The title of my talk today is AF Ablations in the Philippines, Going to the Next Level. So I have no disclosures to make. And the clinical questions we would like to answer this morning are as follows. Why is AF important? What are the treatment goals for AF? When will the patient benefit from a catheter ablation? How do you perform and prepare a patient for a catheter ablation, and what is the local experience on this procedure? So AF is actually the most common clinical arrhythmia among adults, accounting for as many as 3% in the general population. Among middle-aged adults, as many as 1 in 4 will develop atrial fib. And the clinical importance of AF is that uncontrolled AF leads to an increased risk for heart failure and stroke, as has been highlighted by the previous speakers. So locally, this is the closest to the measurement of the ECG prevalence of AF taken from our national survey. So while worldwide it is 3%, our general population has 0.2%. However, emphasizing that this is most probably an underestimate because it is based on a single ECG. And then this will also confirm that among patients older than 70 years of age, the prevalence rises dramatically to 2%. Now, the definition of AF has been highlighted in the various guidelines and ranging from when it is first diagnosed to paroxysmal AF lasting less than 7 days. 7 days is the cutoff for persistent AF, but once it hits a year, it is now called long persistent AF, and it becomes definitely harder to manage. We call it permanent AF once the physician and the patients have given up as far as trying to achieve rhythm control. And then our first speaker has spoken very extensively on silent or subclinical atrial fibrillation. Now, the pathophysiology of AF was first elucidated in the mid-1990s by a group of French electrophysiologists led by Dr. Hasseger, where he actually was able to demonstrate myocardial sleeves extending into the venous connections of the heart. And it is said that the electrical disconnect between the venous sleeve and the left atrial sleeve is what triggers the early part of paroxysmal atrial fibrillation, which on the 24-hour Holter appears as initially PACs, evolving into paroxysmal atrial tachycardia, and eventually into paroxysmal atrial fibrillation. Now, the pathophysiology of AF, however, is not that simple, because at the start, when it is still at its paroxysmal stage, you have increased calcium load, leading to a lot of automaticity, abnormal automaticity, later on even triggered activity coming from the venous connections. However, as mentioned, if the patient has been in AF for at least 5 or 6 minutes, there is already electrical remodeling going on. And this is further aggravated by the RAAS system, the neurohumeral system, and by the time the patient has been in AF for several days, you already expect some structural changes. When the patient is already in the long persistent stage of AFib, 1 year, there is actually atrial myopathy. So when we do voltage maps of the patients who have been in persistent AFib, we see a lot of scarring in the atrium, making it difficult to treat all the more. So this is a very instructive graph included in the ESC guidelines, and it shows for us the evolution of randomized controlled trials showing the treatment for atrial fib. And we will see that back in the 1990s, the first trials were on anticoagulation. Warfarin was actually one of the more studied drugs in the early days, showing decrease in stroke and improvement in survival. But even back then, the surgeons were leading the way. James Cox, with his Mace procedure, showed that when it is done during open heart surgery, even patients in persistent AF or even chronic AF have the chance to go back to sinus rhythm. Then came the AFFIRM trial, which seemed to tell us rate control seems to be as good as rhythm control. And for a while, people seemed to be happy with just rate control. And unfortunately, after that, there was not much evolution as far as antiarrhythmic drug. The only new drug after that was dronedarone, which proved good for paroxysmal AF, but was harmful for persistent or permanent AF. So not much as far as antiarrhythmic drugs. And this is basically the basis for trying to find more interventions to try to control AFib, because drugs have not done very well as far as control of atrial fibrillation. In fact, if we look at the trials, overall, the rhythm control with antiarrhythmic drugs over a span of 1 year or more is sometimes less than 10%, and that includes amiodarone. You will see that initially, for the first couple of years, it seems to work, but less so as you exceed the 1 or 2 year period, and then you run into complications. Now, as far as interventions, there are 2 general types. There's the catheter ablation, which we perform either using radiofrequency energy or through freezing, that is called cryoablation. And then our surgical counterparts perform the Mace procedure. And then lastly, there's a hybrid, where the surgeon and the electrophysiologist work hand in hand to try to control the atrial fibrillation. Now, this is a landmark trial, the APAF study, published in 2006, because this provided the basis for the current practice guideline, both in Europe and in the United States. And basically, it was a randomized trial enrolling 198 patients with paroxysmal AF refractory to 1 drug. And that excludes, however, amiodarone, flecainide, and sotalol. And the treatments were either circumferential pulmonary vein isolation using radiofrequency versus antiarrhythmic drug. And they used trans-telephonic ECG transmissions after a 6-week blanking period. And these are the findings. This Kaplan-Meier curve shows the proportion of AF-free patients for drugs in red, and for ablation in blue. There are two notable findings based on this slide. One is this confirms that drug is largely ineffective, because if you look at the proportion of AF-free patients at 1 year, it is 20%. And comparing ablation, which is around 80%. So based on this, the use of ablation became a class 1 indication if the patient has already failed at least one antiarrhythmic drug. Now, there are a lot of trials showing that aside from mortality, AFib also has an impact on the so-called biomarkers. In this trial, 52 patients were randomized between AF ablation and rate control. And there was a significant lowering of the biomarkers, notably the MR-ProANP and the BNP. Furthermore, aside from the biomarkers, there was also an improvement with ablation in the New York Heart Association functional class. Now, what about for patients who have not yet been tried on antiarrhythmic drug? In 2012 and 2014, drug-naive paroxysmal AFib patients were randomized between RF ablation versus drug, and it was shown that RF ablation was superior to drug in terms of decreasing the cumulative burden of atrial fibrillation. Now, once cryoablation came into the picture, there is the STOP AF trial enrolling 245 patients comparing cryoablation versus drug. And here, the difference is even more dramatic, 70% versus 7%. Now, one may ask, what is the difference between cryo and RF? Intuitively, cryoablation is easier because it uses a balloon, which I will show a video of later, that allows freezing of the vein as a whole, as opposed to RF ablation where you need to do a point-by-point lesion around each of the pulmonary veins. Now, this meta-analysis put together the results that I just previously flashed. And for drug-naive patients, meaning patients who have not yet been tried on antiarrhythmic drug, the odds ratio of being in AFib after an ablation is 0.63 with a 95% interval of 0.44 to 0.92. Now, the results are not as good, however, for persistent AFib, and understandably so, because as we previously described, once the patient is already in persistent AFib, there is atrial myopathy, so simple pulmonary vein isolation is often not enough, so that the success rate for persistent AF is around 40% only or even less. Now, what do the treatment guidelines? I have summarized in this table the current AF guidelines. 2016, last year, was when the European Society of Cardiology released their guidelines, and then 3 years back, the Americans released theirs. The class 1 indication is, as mentioned earlier, for those that have paroxysmal AFib, failed one antiarrhythmic drug. But the European guidelines have elevated it further as a first-line treatment, even for those that have not yet failed antiarrhythmic drug. Now, for persistent AFib, it is only a class 2 indication, meaning it is a second-line treatment. So, to summarize, what are the approaches to AFib ablation? The cornerstone is still pulmonary vein isolation, be it for paroxysmal or persistent AFib. And the reason is, as mentioned, the data that have shown that the pulmonary veins are the trigger in over 90% of cases. Now, we still do not routinely use catheter maze-like lines for persistent AFib, because to be honest, the lines may not be very solid using a catheter when you compare it to the lines produced surgically. And if the lines are not complete, then that may create more problems like flutter, atrial flutter, atrial tachycardia. So it's better to just stick to pulmonary vein isolation. Other approaches, such as the use of complex fractionated electrograms or rotors, have not been proven by clinical trials to really make a difference. Now, what are the preparation involved? Number one is imaging that helps define the pulmonary veins and makes it easier to localize them and isolate them. Then we use either 3D mapping. 3D mapping is a virtual map of the left atrium created using a catheter, and that also helps guide us on where to go. Obviously, to prevent a stroke, anticoagulation is taken very seriously. We don't want to freeze or burn the esophagus, so we monitor the temperature in the esophagus during the ablation procedure. Now, one of the purported complications of cryoablation is phrenic nerve injury. So we take care by pacing the phrenic nerve and make sure that we are not ablating it as we are freezing or burning. So the endpoints when we ablate are we want to show a loss of electrical activity from within the pulmonary veins, and I have a video to show that later on. We also do some pacing maneuvers from in and outside the veins to show electrical block, or the so-called bidirectional block. Now, as part of stroke prevention, this trial was recently published and presented during the last ACC and shows that uninterrupted Dabigatran is superior to uninterrupted Warfarin during AFib ablation. And it included 704 patients undergoing AFib ablation, comparing Warfarin versus Dabigatran. It was an open label, blinded, with adjudicated endpoints. And on Warfarin, the risk of an event was as high as 6%, compared to 1% on Dabigatran. Hence, the practice now is to use a direct oral anticoagulant and not interrupt it even for the ablation. And intra-procedurally, we add IV heparin. Okay, now this cartoon shows the point-by-point burns applied at the antrum of the pulmonary vein. And this is done for each of the 4 pulmonary veins. Now, one can imagine that in a percutaneous procedure, this is quite technically challenging because you need to apply the points contiguously and you need to be angling from the groin so that when the cryoablation came about, this video shows the transeptal puncture. This is the Achieve catheter, which has electrodes that measure pulmonary vein potentials. And then we deploy the balloon. So it's inflated using liquid nitrogen. The vein is then occluded. And the temperature, before that we inject contrast to ensure good seal. Now, once we have a good seal, we then drop the temperature of the nitrogen gas to around -40 to -55 degrees Celsius for around 3 minutes. And we can sometimes do an insurance freeze for 2 minutes. And as mentioned, the endpoint is loss of pulmonary vein potential. So this is an actual case where here the balloon has been deployed, but there is still an inferior leak, as you can see from the contrast injection. After sealing the antrum, We are satisfied now that there is no leak, so that we now commence the freeze. There, you can see the temperature dropping, and it will drop down as low as -40 to -50 degrees Celsius. And the monitor on the left shows pulmonary vein potentials here. If you focus your attention on these complexes, are actually the so-called pulmonary vein potentials, which, as we are freezing, the reason Dr. Bailon here is staring very intently at the monitor is he's watching as the pulmonary vein potentials start spacing out more. And 40 seconds into the freeze, they are completely gone, indicating loss of connection between pulmonary veins there. So no more potentials at 40 seconds. And the next slide shows the graph of the temperature as it drops during the freeze. And the freeze lasts for around 3 minutes, and this is the thaw as we slowly raise the temperature. So what are our local data? We have done a total of 39 cases. 24 of them RF, and 15 are cryo patients. The RF became available around 3 or 4 years ago. And of the 24 cases, it's around half and half, paroxysmal and persistent. And as expected, the results are better for paroxysmal because we were able to take all patients except one off antiarrhythmic drug. And they have remained in sinus rhythm until the current day. Now for persistent AF, 3 had to come back on antiarrhythmic drug, but some of them are partial success stories because whereas before, they were difficult to control with antiarrhythmic drug, going into heart failure, not responding, having very rapid rates. After the ablation, it helped in the sense that they were more responsive to antiarrhythmic drugs. But the main success is in paroxysmal AFib. Now, what about for cryoablation? Cryoablation is newer. It came in around a year and a half ago, and we have done 15 cases, 10 of which were paroxysmal cases. And so far, of the 10 cases, only 1 had a recurrence of AFib. We have done 2 persistent cases, but they are very recent, so they are still in the so-called blanking period. So as you can see, our data are comparable to the data reported in the literature in that we have high success rates for paroxysmal AFib, and we have, I would say, reasonably successful for persistent AF in the sense that they became more responsive to antiarrhythmic drugs. Now, one limitation, however, is that our follow-up is mainly clinical. That means we follow them up in clinic, we request holters and monitors. However, not everyone has an implantable monitor. So we are obviously underreporting the subclinical AFibs. Subclinical AFibs. And that is important because as mentioned by our first speaker, you would of course need to be also aggressive with the subclinical AFibs. Now this trial, Fire and Ice, compared cryo and RF ablation. Because technically, yes, cryo is easier, but is it as good as RF ablation? And this is the answer. They are equally good. It passed the non-inferiority hypothesis with a p-value of 0.74. What are the complications? For RF, there are more groin complications. There are also more flutters resulting from RF because of the incomplete ablations. However, with the first generation balloon, which we already have stopped using, we're using the second generation balloon, there was more phrenic nerve injury, although most of them were temporary and resolved with time. And we are more careful in terms of pacing the phrenic nerve and monitoring its activity. There's also a little more tamponade and effusion with RF compared to cryo, but they have equal stroke rates reported. Now, I just want to show what has been shown earlier, the implantable monitor, which is put under the skin to detect AFib. If the patient has a pacemaker and ICD, then that will serve as the monitor. But in those without devices, this is a diagnostic tool which may be used to pick up subclinical AFib episodes, also AFib among cryptogenic strokes, and also it may have an impact as far as deciding whether the patient's ablation has been successful. And although it's a bit debatable, some physicians in the US even use it to decide on issues of anticoagulation in patients with borderline CHA2DS2-VASc scores. Okay, now, how many of patients will require a reablation? When we say reablation, it means they underwent an initial RF or cryoablation. There was a recurrence of AFib. Then what now? Do you put them back on drug? Or do you try again? If you decide to try again, it's usually easier because it's a matter of sealing the gaps. And we have spiral catheters to show us where the gaps are. But is there additional benefit to trying again rather than just putting them back on drugs? And this study on 154 symptomatic AF patients randomized to reablation versus drugs, and note here, monitored with implantable loop recorders, showed that in a matter of 3 years, if you use drugs, as many as 20% will progress to persistent AFib, compared to if you reablate, where the risk is contained to less than 5%. So another convincing study that shows us that ablation is better than drugs. Now, these are actual 3D maps that show to us how the pulmonary veins, once they are ablated, become electrically disconnected. Because in the pre-ablation, you will see a lot of red, which indicates firing inside the pulmonary veins, which are connected to the rest of the left atrium. But after ablation, note that everything is gray, indicating disconnection. And this is a paroxysmal AFib patient, so you will see that tissue is healthy. But had this been a persistent AFib, you would see a lot of gray as well within the left atrium, indicating scar formation. Now, this is the second to the last slide, and it just shows how we can also work hand in hand with the surgeons for persistent AFibs. This is the classic maze. It used to be cut and sew. But now we have more tools available. So this is the convergent procedure, where the surgeon ablates the posterior wall of the left atrium using suction catheters inserted subxiphoid in the subxiphoid space. So in blue are the lesions created by the surgeon, and in red are the lesions created endocardially by the electrophysiologist. And the data on the hybrid procedure seem to be promising for persistent AFib, although I did not include it anymore in this talk. So in summary, AFib is a serious, common clinical problem. Drugs are ineffective for long-term rhythm control. Based on US and European treatment guidelines, ablation is indicated as first line for paroxysmal AFib and second line for persistent AFib. And our local experience of 39 patients shows good results in both RF and cryoablation. Thank you very much.
Thank you.